So, for those of you who are joining us a few minutes early, we are here in Studio B at WCPO in Cincinnati and 9 on your side with Dr. Daniel Beierbach of the Christ Hospital. We are here for a really important reason. 2.7 million Americans suffer with atrial fibrillation. Millions more probably have it but don't know. And so the Christ Hospital is here to tell us a little bit about why we should care, what we need to know, and answer questions from you. And you can use this same page that you're reading to log in and send us a question. You can also email us a question at webteam@wcpo.com. That's WEBTEAM@wcpo.com, or go over to our Facebook page. So, welcome, Doctor. Thanks so much for coming.
Well, thank you for having me here today. It's always great to get out and talk about atrial fibrillation, such a prevalent disease in not just the United States, but actually the worldwide population nowadays. So, thank you.
You're welcome. So the thing that really struck me was that people may not know they have it. What are some symptoms that might give people a clue and to ask their doctor about?
One of the interesting things about atrial fibrillation is that not everybody has the same symptoms. It's not as though if you break a bone, you feel pain where you broke the bone. Atrial fibrillation tends to present in different ways. Some people feel palpitations or a sensation that the heart is racing and beating very rapidly. Other people feel shortness of breath. Some people can feel chest pain. A lot of people feel fatigue, and that seems to be a driving symptom that brings a lot of people in to see us to seek treatment for atrial fibrillation. So there are many different kinds of presentations. Lightheaded spells are not uncommonly associated with atrial fibrillation. How it will present in any given person depends a little bit on other circumstances, what other problems they might have, such as lung disease or other types of heart disease.
Are there either genetic dispositions or lifestyle factors that could trigger someone to have AFib?
Well, this is a frequently asked question, actually, and there are certain lifestyle modifications that can be made to prevent episodes of atrial fibrillation, to prevent onset of atrial fibrillation, and then once atrial fibrillation has happened or occurred, to try to make the episodes occur less frequently. So some of these things include binge drinking of alcohol. That's very commonly associated with onset of atrial fibrillation. Maybe not at the time that you're doing the drinking, but certainly in the day or two afterward. It's a very common time for people to present either with an initial episode of atrial fibrillation if they're in the younger age category or in the older age categories as well. Certainly, the obesity epidemic in America has contributed greatly to the rise of incidence of atrial fibrillation. So certainly exercise, diet, and weight loss can help. And it helps both directly but also by reducing the incidence of sleep-disordered breathing. A lot of people have breathing disorders when they sleep that's due to a large neck circumference, extra tissue in the neck that compresses the airway and leads to changes in the heart that can promote atrial fibrillation. So sleep apnea is a very big problem for people with atrial fibrillation in that if you have sleep apnea, which is a condition where you have pauses in breathing at night or you get incomplete breaths during sleep, that can very strongly promote episodes of atrial fibrillation, and it's very hard to eliminate atrial fibrillation unless you've treated the breathing disorder at night, the sleep apnea.
So I wanted to just let our folks out there know that the phone number that they're seeing on the screen is for Dr. Beierbach's office. We're not taking questions by phone here. You can get your questions to us through this web chat live on the web. But that number is available to you whether you'd like to call today or another time to get more information, make an appointment, find out a little bit more about how you can learn your risks for AFib. And we actually have some questions, and I'm going to start with one from Jolene. It came in via email. So I'll read the question, and we'll pop the question into our chat so our web viewers can see that, and then you can answer. Does that sound good?
Okay,
here we go.
Good. Let's go.
So this is Jolene. She says she's a 57-year-old female diagnosed with AFib/flutter in 2008. We tried 3 different meds, and then I had ablations for both. Neither were successful. My fib gets worse in spring and fall. Has there been any studies showing that AFib is connected to asthma or allergies? I'm also looking to change meds. What do you say about that? Seasonal or?
Well, I think we should first explain to our viewers that there is a difference between atrial fibrillation, which is a rapid and very irregular rhythm that occurs in the upper chambers of the heart, and a closely related arrhythmia called atrial flutter. Now, atrial flutter is a very organized arrhythmia that tends to occur largely in the right upper chamber of the heart. And atrial fibrillation, by contrast, occurs mostly in the left upper chamber of the heart and affects the other parts of the heart as well. So they're 2 separate arrhythmias, and they have different treatment modalities. Both can be treated with ablation. Now, it turns out that atrial flutter usually can be cured with catheter ablation, and that's a procedure where you come in the hospital and we bring you into the laboratory and perform certain kinds of treatment through the veins in the legs by putting catheters up inside the heart, and we perform a little bit of electrocautery that eliminates electrical conduction in a critical portion of the circuit. So having both atrial fibrillation and atrial flutter, as is the case here, is not uncommon, and we often have to treat them both. Now, in terms of the seasonal variation in symptoms, yes, in fact, there is a direct connection between asthma and other inflammatory diseases of the lungs, such as bronchitis or pneumonia, and atrial fibrillation. The lungs are located right up next to the heart, and anytime you have inflammation in the airways, you're certainly going to have irritation of the heart based on certain chemicals that are released by the white blood cells, the inflammatory cells that are present, and that certainly promotes episodes of atrial fibrillation. So it's a very astute and interesting observation that your symptoms get worse in the spring and in the fall, and I would say that good treatment for pulmonary disease is a critical component of complete treatment for atrial fibrillation.
Jolene also asks, are there new drugs? She says she's taking something called Beta-Pace, and she's wondering if that's good. Are there new drugs? Is there another way to approach this medically, medicine-wise, I mean?
Well, another good question. There are always new drugs being developed for treatment of atrial fibrillation. We have classes of drugs which we call antiarrhythmic drugs. And included in this list are drugs such as Beta-Pace, which goes by the generic name Sotalol.
Okay.
The Sotalol is one of the classic drugs that has been used to treat atrial fibrillation, and for many people works very well. Some of the side effects of Sotalol include a slow heart rate, and some people feel fatigued. There's always a concern with your kidney function when you're on Sotalol, because the Sotalol is processed by the kidneys, so you have to make sure your kidneys are working well. Otherwise, it can actually be a very dangerous drug. So all of our antiarrhythmic drugs are potentially drugs that can initiate episodes of arrhythmias and sometimes very dangerous arrhythmias. So when we talk about antiarrhythmic drugs, we're also very concerned we're always very concerned about what are the potential side effects and who should not be taking a particular drug. Now, that being said, there are a handful of drugs that do the majority of the work in patients who are treated with antiarrhythmic drugs, and Sotalol is one of these drugs. I should mention that any drugs that are in development would, of course, be off-label and wouldn't really be recommended by physicians. although we sometimes do use off-label drugs to treat atrial fibrillation. And one of the drugs that's being investigated right now, but not yet approved for use in atrial fibrillation, is a drug called ranolazine. Ranolazine is approved by the FDA for treatment of chest pain in people who have not been adequately treated by other means. And it turns out that it's been observed that people have lower rates of atrial fibrillation when they're taking this. Now, that doesn't necessarily mean that it's going to pan out and work out to be one of the best drugs for treatment of atrial fibrillation, but since you asked about drugs in development, this is one drug that is actually approved, but not yet labeled
Not for this.
for use
So
in atrial
off-label means
fibrillation.
it's out there, but it hasn't been approved for that particular condition.
That's right. An off-label drug is one typically that's been approved by the FDA for one purpose, but that hasn't been tested for safety and effectiveness for use for another
Can
indication.
you spell that drug?
Ranolazine is spelled R-A-N-O-L-I-Z-I-N-E, and it goes by the trade name Ranexa.
Ranexa. If for our web viewers out there, if you see me looking at my computer, it's not that I'm not paying attention to the doctor. I'm looking for your emails, I'm looking for your comments and moderation, and also on Facebook. So I'm just going to be looking back and forth, but I'm listening completely to the doctor. I wanted to touch on the fact that people in our area, or whoever's watching, wherever you may be, may not know that there are doctors that really have a specialty in AFib, and that's you. So tell us a little bit about what you do that's outside the norm for treating heart disease.
Well, in the world of heart doctors, we're divided into a number of different subdivisions. Some heart doctors treat heart disease with primary prevention. Other people are imaging specialists. Some heart doctors treat the plumbing of the heart, blockages in the arteries. And then there's what I do, which is called electrophysiology, and we treat rhythm disturbances of the heart. So the electrical system of the heart is our domain. Now, within the world of electrical problems that can happen to the heart, there are arrhythmias such as atrial fibrillation. And the most prevalent, the most common of these arrhythmias is atrial fibrillation. So I am a specialist in treatment of atrial fibrillation, and this includes everything from clinic management of patients with symptomatic atrial fibrillation and asymptomatic atrial fibrillation to treatment with procedures such as an electric shock treatment to the heart. That's called cardioversion, and that's meant to restore a normal rhythm. All the way up to very complex ablations that require an overnight stay in the hospital, that are performed under general anesthesia, and that are actually very safe, but take a lot of people, a lot of personnel, and a lot of equipment to accomplish safely and effectively.
Well, we have our first question here via the web directly. It's from Elaine, and she's asking, what if an AFib test, EKG, or Holter monitor show no irregularity, but there is occasional palpitation when she has extreme exertion? What is your thinking there? Again, that's what if AFib test, EKG, or Holter monitor, I don't know what a Holter monitor is, but if any of those show irregularity and she has palpitations, what does that mean for her?
Well, this raises a concern about how do you go about figuring out what's causing somebody's symptoms. So somebody comes in and they say, you know, I feel skips in my heart, I feel extra beats, or my heart is beating more forcefully. It's not doing it right now, so how do we figure out what it is that's causing these problems at home or while you're exercising? So we have certain tools. The easiest tool is, or the most commonly used tool is an EKG, and that's where we put some patches on the chest and we get an electrical recording of the electrical activity that's occurring in the heart. And that tells us a lot of information about the heart's rhythm. Well, if you're not experiencing symptoms at the time that we do the EKG, then we have nothing really to correlate. Mm-hmm. So we sometimes send people home with what's called a Holter monitor. And a Holter monitor includes the same electrical hookup with patches on the chest, not as many as an EKG, but enough to where we can get good information. And you wear this usually from anywhere from 24 to 48 hours. And if you do happen to have palpitations while you're wearing the monitor, You write down what time it occurred, and then we look back at the information and we see what was going on with the heart's rhythm at the time you had the symptoms. And this allows us to get very valuable information about what's happening with the electrical system of the heart while you're having your symptoms. So that's a Holter monitor. We also have one that you can wear for longer called an event monitor or an ambulatory event monitor. You can wear this up to 30 days typically. And if you have symptoms, again, you write down when they occurred, and then we're able to correlate what the arrhythmia was while you were having symptoms, and this tells us how to treat it. Now, you may have worn a Holter monitor and didn't have very pronounced symptoms while you were wearing the monitor, or it wasn't your typical symptoms, and sometimes it just takes more monitoring to figure it out. But some people do experience feelings or sensations in the chest that are not associated with a heart arrhythmia, and then we have to look in other areas to see what that might be. One of the common things that can occur, particularly for people who are exercising, particularly with either light weights or heavy weights, is you can get little twitches of the muscle tissue, either in the surface of the chest or sometimes a little bit deeper down, and we call these fasciculations, and they sometimes can mimic palpitations. Other people just have nerve firings that's more of a neurologic issue than it is really a heart or a muscular issue.
So we just got a question from Facebook that we had touched on, but I wonder if you wouldn't mind repeating. Will is asking, is AFib hereditary? His father has it.
Yes, I didn't finish my answer to that question, so thank you for asking again, Will. There have been certain genes. Right now there's 4 clearly identified genes that significantly increase your risk of getting atrial fibrillation. So there is some heritability to the disease. One of the problems with trying to look for a genetic basis of atrial fibrillation is that it's a very common disease. So if many, many people have it, it takes a very large number and very thorough investigation to come up with genes that might be playing a role as opposed to just environmental factors or just age.
Okay. We have another question via our web chat, and it is from a Melissa. Can you comment on the findings from the recent TREAT AF study? Does that ring a bell? Where do you stand on digoxin for patients with AFib?
So the TREAT AF study is one in a line of studies that have looked at the potential dangers of using digoxin for treatment of atrial fibrillation. Now, I should preface this by noting that digoxin is one of the oldest medications we have in the heart arsenal and has been used for years, literally over a century, for treatment of different kinds of heart conditions, including atrial fibrillation, but also for heart failure. Okay, to give you an example, digoxin is derived from a plant called the foxglove plant. It's a little flowering plant, actually very pretty, and people used to chew the leaves of the foxglove plant and found that that helped with their symptoms of both heart failure and palpitations. Digoxin works by slowing down the heart rate, but it turns out, as with many medications, that it also can have some dangerous side effects. Okay? First of all, it's not a very effective medication for treatment of atrial fibrillation because it tends only to slow the heart down while you're at rest. If you get up, you start moving around, you're exercising, digoxin is really not a very good rate-controlling medication. It's not classified as an antiarrhythmic drug because it really doesn't have the potential to reduce the frequency or severity of episodes of atrial fibrillation, particularly for active people. So we sometimes use it in hospitalized patients. We use it in patients who are not very active. But it is a legacy drug in the world of cardiology, and many cardiologists still use it, particularly as a first-line drug to control the heart rate. And that's really because it has a low side effect profile and it's relatively benign. Okay? But the recent TREAT AF study, again, looked at, it was a retrospective study, and it looked at let's take a view of all people who have been treated with digoxin and see if the outcomes are better for those people or worse. And it turned out that there was a little bit of a signal to indicate that digoxin might actually increase mortality in the patients that were selected in this particular study. So there's a lot of subtleties to the study, but the point is that it's not the first study to indicate that digoxin might actually increase mortality in patients who have atrial fibrillation.
Well, if you're just joining us here in our special web chat, I'm here with Dr. Beyerbach of the Christ Hospital. We're answering your questions about AFib. And actually, we just got a shout out for you via our web chat. This is from Andy. And Andy says, I just want everyone to know that I had cryoablation surgery. Did I say that right?
Yes, you
cryoablation
did. Yeah.
surgery by Dr. Beyerbach, and it was the best thing I ever did. I thank him so much. I am AFib free for over a year. Thank you. So, high five. Great. It works.
It's always wonderful.
We
to
got
hear
a real comment. So real comment from a real
stories.
person out there. Thanks, Andy. And if anyone else wants to get in on this, you can go to WCPO.com. You'll see it right at the top of our page. You can click on it and get into our chat. We've got a question from Donna, also from our chat. And Donna is saying she has a brother who's 23. He drinks 2 to 3 big cans of Monster, the caffeine drink, at least every other day, sometimes every day. He has Crohn's, and they have shocked his heart twice. Can these Monster beverages have put his heart in AFib? So can these caffeine drinks that are so popular, she's watching his intake very closely, apparently.
Yeah.
Is there some correlation there?
Well, it's a very good question. The concern is the caffeine content of these either energy drinks or caffeinated beverages that have higher doses than usual of caffeine. The same thing can happen for people who drink a lot of caffeinated sodas like Coca-Cola or Pepsi or anything that has caffeine, such as tea. Coffee is a high content of caffeine, obviously. In the mornings, people drink a lot of coffee. So there's been a great deal of interest in caffeine as it relates to atrial fibrillation, because we know that caffeine certainly increases your risk of heart arrhythmias, including heart arrhythmias that present as palpitations, people feeling skip beats or extra beats, or even just the heart beating more rapidly or more forcefully. Well, it turns out that it does promote extra beats, extra single beats in the upper chamber as well as in the lower chamber.
So this is caffeine, you're saying now?
Yeah, caffeine does this. It causes PVCs, it causes APCs, and these are extra beats, atrial premature complexes or beats, and ventricular premature complexes or beats. So yes, caffeine does play a role in certain arrhythmias. Now, with regard to atrial fibrillation, the largest study that I've seen is a study performed in Scotland. It's called the Renfrew-Paisley study, and they took a retrospective look at 40,000 people. So 20,000 people who drank coffee on a regular basis and 20,000 people who abstained from caffeine entirely. And what they found was kind of interesting. They did not see an increase incidence or prevalence of atrial fibrillation in people who were coffee drinkers.
Okay.
There have even been some studies to suggest that caffeine, through its effects in the liver and certain hormones, may actually have some sort of preventive effect against atrial fibrillation. Now, that being said, I can tell you anecdotally that there are many people who tell me that they have atrial fibrillation and they only ever get episodes after drinking a lot of caffeine. So it may be a confusion of what arrhythmia is causing the symptoms, but we don't have hard scientific evidence to date to suggest that caffeine is really a big risk factor.
And as a lot of doctors will tell you, moderation in all things.
Moderation
right?
is a good idea. You know, and one of the problems with these caffeinated energy drinks is that young people in particular are combining them with alcohol. And that's a particularly dangerous combination.
Interesting.
Yeah.
So we have one of our other emails. This is Nancy. Nancy says she has periodic heartbeat skips, big ones, sometimes many times a day in one day, but then not for a month or so they're not consistent. Is this something I need to get checked, or is this nothing to worry about?
Well, it's hard to say what is, bears worrying about or not worrying about. I mean, the easiest thing to do is to see a health professional and get an assessment, which typically will include an EKG or one of these monitoring devices, such as a Holter monitor or event monitor, as we mentioned earlier. And then it usually will be diagnosed as either early beats that are occurring in the lower chamber of the heart. We call those PVCs, for premature ventricular contractions or complexes, or single early beats that occur in the upper chamber of the heart, atrial premature complexes. And usually these are not something to worry too much about, but it's hard to comment specifically about any kind of individual case without more information. You actually have to have a complete picture before you can make an assessment of, how dangerous is this, but usually they're benign.
But it should be worth checking out probably for peace of mind,
It's
if
always,
nothing else.
I would say it's always worth checking out and getting a definitive diagnosis if for nothing else, peace of mind, but also because it may lead to further assessment of the heart. Usually an echocardiogram will be in order. This is an ultrasound picture of the heart that tells us a lot of information about how the heart pumps, how strongly it's pumping, and whether or not there might be any kind of valvular problems that could be leading to these extra beats, and that might be something that's worth catching early.
That's good. I got another email here. This is from Julie. And Julie says she had something called a mini maze procedure 2 years ago. She continues to have AFib and aflutter. She's scheduled to have an ablation in October. My question is this: do ablations weaken your heart each time you have one? Can you tell us what a mini maze is first?
So let's start with the mini maze. There are a lot of different ways to treat atrial fibrillation, and the maze procedure really was developed as an adjunct to heart surgery, open heart surgery in the beginning. It was developed by Dr. Cox in St. Louis, and he showed that he could successfully prevent episodes of atrial fibrillation by literally cutting up the left upper chamber of the heart and sewing it back together. And this created lines of scar tissue, and electric current doesn't conduct readily across scar tissue, and so this divided the heart up into various channels and effectively prevented atrial fibrillation for a lot of people. So as several iterations and variations on this surgery, what many cardiothoracic surgeons are performing nowadays is an invasive procedure where you have 4 or 5 holes placed in the chest wall, and instruments are introduced into the chest cavity under general anesthesia. And then there are lines of scar that are created on the outside of the heart with equipment that usually heats the heart muscle tissue up and creates scar tissue there. So this is an attempt to recreate this original maze procedure that was performed by Dr. Cox. It's usually requires a 3 to 5 day stay in the hospital and can involve a lot of pain, so you have to use pain pumps through an IV. It's not really one of the treatments that you would consider as an initial treatment for the kind of atrial fibrillation that tends to come and go on its own. That would be considered too heavy a hammer, if you will, to
and
use.
so she's asking too, if she has more than one ablation, do these tend to weaken your heart over time and then cause more problems?
Well, in general, there's not really a concern that the heart pumping strength is going to be weakened with additional ablation procedures of the standard variety where we go in through the groin area with catheters. There are some people who have already weak hearts and their heart is working maybe only at 20% of a normal heart pumping strength. And then in that kind of case, you don't have as much healthy heart tissue. Now we're talking about the lower chambers of the heart and not the upper chambers. In that case, certain kinds of ablation, you have to be careful. But for atrial fibrillation treatment, usually you're not going to see a weakness in the heart pumping strength with repeated ablations. And if anything, by maintaining the heart's normal synchronization, if you're able to maintain a normal rhythm through ablation, you may in fact improve the heart's output.
That's great. If you're just joining us, the number behind us is a number to Dr. Beierbach's office. If you have further questions, we're taking your questions here via the internet, but if you have questions or are interested in making an appointment, touching base with the doctor, the number behind us, that's what that number is for, and there are people there to take your call. We touched on this earlier, AFib and sleep apnea, the relationship, and Sleepy Mike, he's got an appropriate name for his handle online. Sleepy Mike asks, can sleep apnea cause AFib directly?
Well, the answer is yes, through a number of different mechanisms. What happens with sleep apnea for people who have obstructive sleep apnea, there are two kinds of sleep apnea, obstructive and central, and then a third kind called mixed. But obstructive sleep apnea is where the body is trying to take a breath, but no air is going in because the throat is collapsed or partially collapsed. The tongue may be back against the back of the throat, particularly when you sleep on your back. And under this repeated effort of trying to take a breath and no air flowing in, what happens is that the pressure inside the chest drops, which would normally cause air to flow in, but instead no air flows in, and that creates a force on the upper chambers of the heart that makes them enlarge. And as they get bigger, they tend to have reactive scar tissue formation that can lead to atrial fibrillation. Additionally, that's more of a chronic effect of sleep apnea. But additionally, acutely, while you're not getting a breath, your carbon dioxide level in the blood rises and your oxygen level drops. There are certain hormones that are eluted that come out into the blood because of this. It's a response to not getting a breath. And the nervous system, the body's nervous system gets revved up. So yes, sleep apnea has a pronounced effect on promoting and actually causing atrial fibrillation, both in an acute and a chronic way.
We have another question by email. Jerry asks, what we touched on way in the beginning of our talk, how do I know if I have it? I was diagnosed with PVCs. What's PVCs? Remind us, and then tell us, how does he know he has it? What are those symptoms again?
Well, good question. When you have palpitations, you really don't know for sure what you're having electrically in the heart without one of these instruments we've talked about, either an EKG or a Holter monitor, to show what the heart's electrical activity is doing. So if you're having PVCs, the way to find out is to get an EKG. It's very hard for some people to tell when they're having atrial fibrillation just based on heart symptoms. Now, other people who've had both arrhythmias can tell in an instant if it's their typical atrial fibrillation, which tends to be very irregular heartbeats, rapid heartbeats, whereas PVCs, if you're trying to figure out a way to discriminate them, PVCs can occur as just either single skipped beats without necessarily an increase in heart rate, or they can occur as more forceful beats. People experience PVCs differently. PVC, again, stands for premature ventricular complex or contraction.
So I wanted to just go back and review some basics, again, for people who are just joining us. One of the questions that people are always going to come to the doctor and say is, how can I be cured? What's the cure? What's the fix? So is it treated simply by medication? Is it behavior modification? Is it a procedure plus the other things? What is it that you do to treat AFib?
Well, thank you for that question. I think we really have to clear one thing up here, and that is that atrial fibrillation is a multifactorial chronic disease process. And just like, as is the case with high blood pressure or diabetes, we really don't truly have a cure per se. Some people will say that they're cured of atrial fibrillation. Even some physicians will promote a certain treatment as a cure. I find that to be less than accurate. Okay? There's not been a method endorsed by any of the heart rhythm societies, such as the American College of Cardiology, the American Heart Association, or the Heart Rhythm Society, as being a cure for atrial fibrillation. So the way we approach atrial fibrillation is we treat it as a chronic disease process, and we manage it. So for some people, that means that they may go years without having any episodes of palpitations, but you have to understand that the underlying mechanism that allowed atrial fibrillation to occur in the beginning is still always going to be there to a certain degree. Yeah. And so we do a good job, usually if we're trying to follow a strategy of controlling the heart's rhythm, in other words, trying to keep the heart in a normal rhythm, then we have antiarrhythmic drugs that we'll usually try first. We have tools to get you back into a normal rhythm, electrical cardioversion, and then we have ablation, which is really an effort to eliminate the triggers that will promote episodes of atrial fibrillation and thereby give you long periods of time in between episodes of atrial fibrillation.
The questions that we've been getting have come from people of different ages. So, which raises a question to me, is there an age that you need to really be looking at if you have heart palpitations that it might be a factor, AFib might be at work, or is it, it can be anybody, basically?
Well, it can be anybody. It tends to be a disease that occurs in the later decades of life, but we certainly have a large portion of patients in their 40s who have undergone treatment with antiarrhythmic drugs and ultimately ablative therapy. So it can occur in the 40s. In younger patient populations, it tends to occur in special circumstances, either well-trained athletes who have very slow heart rates due to certain kind of nervous system output called vagal tone. That's one category of younger patients who get atrial fibrillation. The older population, for instance, if you look at the Medicare population, this is a population on which we have a lot of data collected, and we can say that of the Medicare population age over 65, 9% of that population has atrial fibrillation. So it really is a very prevalent disease in later decades of life. We start to see the curve go up around age 40, but really between age 40 and age 60, a small percentage of patients get atrial fibrillation.
So about the time we need to be watching some other things, this could be at play as well.
That's right. As a matter of fact, you bring up an interesting point because at about age 50, people are usually recommended to get a screening colonoscopy, and we have a lot of people whose atrial fibrillation is picked up at the time of their screening colonoscopy.
Interesting.
Yeah.
I can see how that could be. So this is more of a comment from Stephanie via our web chat. My aunt passed away from a tear in her aorta this year, and she had AFib for years despite many treatments that failed. Could AFib have caused the tear in her aorta?
Well, those are probably two unrelated disease processes. There are many different reasons why somebody might have a tear in the aorta, and we call this aortic dissection. Okay. There may be a commonality between the two if there was atherosclerosis or cholesterol buildup in the walls of the big artery, the aorta, in the central portion of the chest and abdomen. Atherosclerosis, we know, is associated with atrial fibrillation. It's one of the more frequently associated comorbid conditions with atrial fibrillation. But that's probably largely because there is a large percentage of the population that has atherosclerosis and a large percentage of the population that has atrial fibrillation. So there's naturally going to be a large overlap. It's not clear that there's a very strong cause and effect relationship between the two.
So here's another one. This is from Lois. Does AFib tend to become more pronounced so that if you have an incident, say once a month, you may start having one more frequently, thus making it easier to diagnose? It's an interesting way of putting it.
Well, this is true. Atrial fibrillation, because it is a chronic progressive disease process, people may have an episode in their 40s and don't really know what it is, and it doesn't last long, and so nothing is really done about it. And then maybe 10 years later, the next episode might occur, but eventually episodes start occurring more frequently. And this just reflects that it is a chronic disease process and that you are going to continue to get more episodes. The natural history of the disease is that you get your initial episode and maybe a while, but you eventually start getting so many episodes that you then seek out care. So yes, you will get more frequent episodes, and it does, in a sense, make it easier to diagnose just because it doesn't take as long to document that you're having an episode of atrial fibrillation.
So here's a question. Different doctors are going to approach AFib maybe with a different degree of how severe it might be. If there's someone that feels like their doctor is not, doesn't feel like if they're worried and they're not getting the answers they want, what are some of the things that they can do to get a little bit more information, maybe some screening and that type of thing?
Well, that's a good question. There is a lot of misinformation about atrial fibrillation. It is a very large topic, and there's many people investigating various aspects of diagnosis, management, treatment of atrial fibrillation. So new studies are being published on a daily basis, literally in hundreds of journals. It's really hard to keep up with all of the changes in the management and treatment of atrial fibrillation unless that's your specialty. So my advice to somebody with atrial fibrillation who feels that they're not getting the answers or they think that there's some uncertainty as to their course of treatment would be to seek out an atrial fibrillation specialist.
And you are just that.
I happen to be one of those,
You
yes.
happen to be one of those. And that's your number on the screen behind us. You know, I wanted to go back. What Will, who sent us a question via Facebook, just sent us another question saying, or just sent us another saying he just missed the answer. So just
Okay.
for Will, we're going to re-answer. Basically, he was the one who asked, his dad had AFib, is it hereditary?
Yes, atrial fibrillation, there has been a hereditary component identified, and as I said before, there are about 4 clear genes that have been identified that may transmit the disease clearly, but we think that that component of atrial fibrillation affects a small percentage of people who have atrial fibrillation. Some of the hallmarks of inherited atrial fibrillation is that there's many family members that are affected. Now, this can happen by random chance because it's a prevalent disease, but if it affects many generations, that leads you more strongly in the direction that there may be a genetic component to it. Either way, the treatment so far is pretty similar.
Good to know. And if you're, we've gotten quite a few questions by email. If that's the way you would prefer to send us your question, the address is as follows: WE, B as in boy, T as in Tom, EAM as in man, at WCPO.com. And we just got a question in from Carol. She's asking, what is your opinion on warfarin use or one of the new 3 anticoagulant drugs?
Well, excellent question. One of the big problems with atrial fibrillation is that it predisposes people to getting a stroke. Stroke can be a very devastating occurrence when it happens, particularly in the setting of atrial fibrillation, because these strokes tend to be large strokes and people tend to have a less complete recovery. So you may lose the ability to speak, you may lose the use of your right arm, your right leg. These are very common types of strokes with atrial fibrillation. So one of the big concerns with atrial fibrillation is how do we prevent stroke? And the way we do that is with blood thinners. Now, the most common and most tested blood thinner is warfarin. It goes by various trade names, including Coumadin. And in fact, there are a lot of hospitals and areas in the country that will have a Coumadin clinic. And the Coumadin clinic is there because when you're on warfarin, you have to get your blood tested to see how thinned out it is by your current dose of warfarin. So that requires regular follow-up, regular blood testing, and frankly, it's a little bit of a hassle. So there has been great interest in developing alternatives to warfarin, and we now have, fortunately, 3 new drugs available that are equivalent in their stroke protection, and at least one of them provides mortality benefit over warfarin. So these 3 drugs go The first one that came out was dabigatran, which
Can you spell these as while you're
Sure,
at it?
yeah. Dabigatran is Dabigatran,
Okay.
and that goes by the trade name Pradaxa.
On some of these we've heard commercials for. We know
You'll
we've
certainly
we've
hear
seen-
commercials for
so
these drugs.
Pradaxa, and what's the real word? What's the actual name of it?
Dabigatran.
Dabigatran or
Yeah.
Pradaxa? Okay.
Yeah, Pradaxa. So that was the first one to come out, and it did show equal protection, if not better protection, against stroke. And there's trade-off. There was less bleeding in the brain, more bleeding in the gut. It can cause some bad stomach feelings. Some people get stomach pain or nausea with it. So there's downsides to any drug, but overall it provided equal protection against stroke, and or even better protection against stroke. So that was the first option. The second option was rivaroxaban. That's Rivaroxaban, and that goes by the trade name Xarelto with an X.
Xarelto, yeah, I've heard of that
so
one
you'll
too.
have heard of that one, yes. And this is a once-a-day medication that, again, provides equal, if not better, protection against stroke. And you don't have the hassle with any of these newer drugs of having to get your blood tested. Now, on the flip side of the coin, we don't have any way of monitoring the effect of the drug on your particular system. We just know from population studies that it seems to protect against stroke. We have no reversal agents available, and that means that if you start bleeding for whatever reason, you're in an accident or you injure yourself somehow, we don't have a good way to reverse the blood thinning effects of these newer anticoagulant drugs, these newer blood thinners. The third anticoagulant, or novel oral anticoagulant as we call them, is apixaban, and that's Apixaban, and that goes by the trade name Eliquis.
And another familiar one.
Yes,
Yep.
you'll have heard commercials for all of these. And so apixaban provides not only superior protection against stroke, but also, as I mentioned before, has mortality benefit over warfarin. It is a twice-a-day drug, and again, these drugs are more convenient. They're certainly more costly because of their convenience and because they're newer drugs. As we all know, drugs when they first come out are really very expensive. So as an example, you might expect to pay anywhere from $5 to $10 a month for a month's supply of warfarin, whereas with a newer drug like rivaroxaban or apixaban, you may be paying several $100s a month for the same month's treatment.
Wow.
Yeah.
So that was from Carol. I hope that she got some good insight into those three other drugs. I wanted to go inside your office for a second virtually. So someone comes in and they feel that they may have AFib, or they know something isn't quite right. What are some of the questions you're asking them, and what are some of the things that your first couple of steps in terms of treating after you figure out that they may have AFib?
Well, so one of the first steps, of course, is a complete history and physical examination, and we do that with everybody that comes in. Specific to atrial fibrillation, though, we're going to be looking at your stroke risk. So we're going to be asking questions that tell us and allow us to predict in a very accurate way, percentage-wise, whether or not you're at high risk, moderate risk, or low risk of having a stroke because of the atrial fibrillation. So that's of paramount importance. So we create your stroke risk profile, and we can tell you exactly what annual percentage stroke risk you're going to have based on studies that have been done in this area. And then secondly, we're going to make an assessment of what kind of atrial fibrillation you have. Yeah. So we haven't touched on this yet, but there are different kinds of atrial fibrillation. There are different names of these different stages of the disease process, really. So your first episode of atrial fibrillation we refer to as primary atrial fibrillation. And then after a while, as we mentioned before, you may get episodes that come and go on their own without doing much, without you having to do much about it. And this stage of the disease process we call paroxysmal atrial fibrillation, coming and going on its own. Eventually, if left untreated, atrial fibrillation will progress to persistent atrial fibrillation. And unfortunately, sometimes this is the stage that we find people in when they first come for evaluation. So emphasizing the importance of getting in early, because we have much more success at treating paroxysmal atrial fibrillation than we do with treating persistent. But persistent atrial fibrillation comes and it stays for at least 7 days. And if you've had atrial fibrillation continuously for 7 days in a row, well, then we classify it as persistent. Permanent atrial fibrillation is where we've decided in discussion with the patient that we're no longer going to try to maintain a normal rhythm, that we're going to accept atrial fibrillation and follow an alternative strategy of controlling the heart rate. And we call this the rate control strategy. So there are different stages of the disease process, and we certainly want to assess what is your stage. Next, we want to know what are the causes of atrial fibrillation for a particular person when they come in. So we do a complete workup at the various causes of atrial fibrillation, including checking things like your thyroid function, looking for sleep apnea, seeing how well your blood pressure is controlled, looking at your lung disease processes. So a number of other issues like this that allow us to tailor treatment to a particular individual in order to treat this chronic, ongoing disease process. So we have to treat all the causing factors in order to be successful. And then finally, we're going to come up with a tailored treatment program, making the decision based on all of this information, what is the right approach for this particular patient.
So there's, can you recap those three different, because I don't know that people know that there are those three stages. Can you recap those for us again?
Sure, yeah. So paroxysmal atrial fibrillation is a type of atrial fibrillation that comes and goes on its own. It never lasts very long, certainly not more than 7 days. Persistent atrial fibrillation is atrial fibrillation that comes and stays usually until you do something about it, like an electric shock treatment, cardioversion, and it stays for at least 7 days. And then permanent atrial fibrillation is atrial fibrillation usually that is continuously present, but where a decision has been made that it's just not going to be very successful strategy to try to maintain a normal rhythm, or decision has been made between the physician and the patient that we're not going to try to maintain a normal rhythm, and there can be any of a number of reasons for doing this. But then the alternative is a rate control strategy.
You touched on stroke.
Yes.
And I wanted to ask you, what are some of the other things? So stroke is something, is the correct term comorbid? Is that the medical term? Something that these things can coexist and make each other worse, basically. What are some of the other things with stroke and any other conditions that can coexist with AFib?
So let's take stroke. Stroke would be considered a complication of atrial fibrillation, so that's usually how we would refer to stroke, because people who have atrial fibrillation may not have gotten a stroke except for the atrial fibrillation. And so it really usually is a consequence or a complication of atrial fibrillation. Comorbid conditions are conditions that exist in addition to atrial fibrillation. And one of these common conditions is heart failure. And that's another big landscape and a huge area of specialization. We have heart doctors who specialize in treatment of heart failure. And heart failure is a condition in which you frequently will find atrial fibrillation because the things that lead to the heart not functioning well also can promote atrial fibrillation. So it's not uncommon to see atrial fibrillation in the heart failure population. And by itself, atrial fibrillation then, in turn, by making the heart beat more rapidly and less efficiently, can make heart failure worse. So heart failure can exacerbate, atrial fibrillation can exacerbate heart failure, and heart failure can cause atrial fibrillation.
Another common question that we know people ask is that someone may be already on a medication to help treat AFib, but they don't feel that it's really working. What would you advise in that case?
That's a very individual assessment and decision-making process that is not necessarily the same for everybody. The things that are in common is that we usually will try an antiarrhythmic drug for people who have paroxysmal atrial fibrillation, even for people who have persistent atrial fibrillation. And antiarrhythmic drugs have limited utility in that regard. They may help a lot of people, and a lot of people can go long periods of time in between episodes when they're treated with an antiarrhythmic drug. But as I said before, there's really not a good cure for atrial fibrillation. So you're always going to have breakthrough episodes. You're always going to be at risk for getting more episodes of atrial fibrillation, irrespective of what particular drug you're taking. So it's usually a complicated decision process as to what you're going to do next. But in general, if you've tried an antiarrhythmic drug and you're still having symptoms from atrial fibrillation, usually that's the time where you start to think about ablation.
Okay. One of the things that struck me when we asked you before today for information on just some 10 tips that 10 things we should know about AFib. The thing that, again, I mentioned this in the beginning, it really struck me was that we know that about 2.7 million Americans have AFib. We think it could be as high as 6 million. What is going on in the lives of those other 4 million that they should be looking for to see if they may have an issue here?
So you're asking the question of how can you assess whether or not you're at risk for developing atrial fibrillation. And it's hard to know. We have certain risk factors that we know will lead to atrial fibrillation. We've mentioned heart failure. High blood pressure is probably the most common promoting factor in people who have atrial fibrillation. High blood pressure leads to changes in the heart that will promote atrial fibrillation. Some of those changes include things like thickening of the heart wall. So the lower chamber of the heart is a muscle, just like other muscles. It's a slightly different kind of muscle, but in response to a higher load, in other words, higher blood pressure against which the heart has to pump, the heart muscle thickens, just the same way a weightlifter will have thicker muscles from lifting weights repeatedly. So this leads to a stiffness in the heart, and the heart doesn't relax as well. And so that'll promote atrial fibrillation. So there's a number of different ways in which high blood pressure can promote atrial fibrillation, but that's an example of one of them. Other things to look for are thyroid problems. So thyroid disease, particularly an overactive thyroid, can promote atrial fibrillation. We've touched a little bit on lung diseases, so people with pneumonia, people who have bronchitis, asthma, these people are at risk for getting atrial fibrillation. But probably the single most powerful and prevalent promoting factor is age, and I'm sorry. We haven't yet found the treatment for that.
Speaking of age, we have another question from Carol, and she says, can you explain the relationship between excessive exercise, and she's giving the example of ski racing, extreme ski racing, so excessive exercise and AFib in middle age? And I'm thinking middle age might be 40s and higher.
Sure, yeah. Well, we do have a population of people who are avid runners. That's become quite a movement in the last few decades, certainly in the United States, if not worldwide. We have cyclists and any kind of athletic endeavor where your heart rate is up and you're exercising for extended periods of time certainly can lead to an overall lower resting heart rate. And that reflects a certain nerve tone, which we call vagal tone. Now, there are two general categories of nerve inputs to the heart. One is the vagal tone, and the other is the sympathetic drive to the heart. And the sympathetic drive tends to speed the heart up, and vagal tone tends to slow it down. Well, somewhat paradoxically, vagal tone, although it slows the heart down, it predisposes you to getting atrial fibrillation. It sets the heart cells up to recharge faster, and what you need is the heart cells to be able to discharge their electrical activity and then recharge quickly in order to be able to support this fast and irregular arrhythmia called atrial fibrillation. So the underlying mechanism of atrial fibrillation is a little bit promoted by people who are in really good athletic shape. So It's a little bit ironic,
It
but
is.
this electrical problem can occur in very well-conditioned athletes. So that's the connection I would see there. One other comment I would make is that there's been some recent evidence that if you have high levels of input from both the sympathetic and the vagal nerve inputs to the heart, that in itself may be a promoter of atrial fibrillation. So that's a little bit tantalizing. It's in the bench stages right now, and clinically it'd probably be difficult to prove, but that's an underlying theory that's been proven to a certain degree.
Wow. Well, I wanted to mention the phone number that we have up on the screen behind us. This is directly into the doctor's office. You can call 513-206-1180. That is a place to ask questions, make appointments, or just learn a little bit more about Dr. Beierbach's practice in treating AFib. I wanted to go back, again, for those people who maybe joined us later. Symptoms vary widely, but can you give us again a recap of what those symptoms are?
Well, some of the common symptoms that we see are palpitations or a sensation that the heart is beating rapidly or irregularly in the chest. Some people have chest pain because of this. Some people have a lot of anxiety because of their heart having palpitations. Shortness of breath, particularly with exertion. So people will say, well, I feel fine until I try to climb a flight of stairs, until I try to walk uphill, you know. And that's a situation that's commonly associated with atrial fibrillation. Fatigue is probably one of the most common symptoms that people have. Younger people tend to feel fatigue for up to a day after even a brief episode of atrial fibrillation. The episode may only last an hour, but they're fatigued for the rest of the day, they say. And in later decades of life, just constant fatigue. And it's hard to tease out, you know, is the fatigue associated with the atrial fibrillation per se, or are both the atrial fibrillation and the fatigue related to underlying sleep apnea, where you're not getting deep sleep at night, you're not getting complete sleep at night, and it's really the sleep apnea that's causing both the fatigue and the atrial fibrillation. Chest pain is not uncommon. Shortness of breath at rest can occur. Lightheadedness, some people feel faint when they're having episodes of atrial fibrillation. And some people, unfortunately, but some people feel really nothing. They say, Doc, I am feeling fine. Why am I here? And it's because one of their treating physicians has sent them over for further treatment of atrial fibrillation.
I wanted to go to, we're about to wrap up. I don't see any more questions coming in, but I wanted to just ask you any final parting thoughts, if nothing else, do this or don't do that for our web chat viewers.
Well, thank you for that question. First of all, I would say that we have to recognize that atrial fibrillation is an epidemic. It's been documented as such, it's been written about as such, it's been published as such. It's an epidemic in the United States, but also worldwide. We think that part of the reason that it's an epidemic is just because of the large population of baby boomers that are reaching the age where you might get atrial fibrillation. But it's also the obesity epidemic, high blood pressure. There's a lot of salt in the American diet in particular. The best thing you can do if you think you might have atrial fibrillation is be evaluated by a health professional. Have your atrial fibrillation documented, and then if it's appropriate, get referred to an atrial fibrillation specialist, because early intervention really is the key to a successful outcome. We have much better results with ablative therapy in particular when we're able to get in there early in the disease process, and we can halt all of these other factors that are causing the atrial fibrillation and get those treated as well.
I wanted to do the phone number again because we want to make sure that everyone sees it. And do you know it by heart without turning around?
It's 513-206-1180.
Okay, and do you practice where? Where is your office located?
I have 3 different offices. I practice on the Christ Hospital campus downtown. I'm also in Northern Kentucky on Dixie Highway in Fort Wright, and also up in Liberty Township near the Children's Hospital facility as well.
So you just run from office to office all day, right?
Yeah, all 3 places every day, that's right.
Well, oh my goodness, we got one more question. Let's do this
Okay.
one. How do you test for AFib? Good question to end.
Again, to recap, testing for atrial fibrillation involves a complete history and physical, but very specifically, an EKG is the real tool that we use, and that's for the time when you're having symptoms. If you're not having symptoms at the time, then we'll use a longer type of electrical monitoring called a Holter monitor or an ambulatory event monitor.
And the Holter is the thing that you can take home. And,
Holter, you
right.
take it home. It's a little box that you wear on your belt buckle. Yep.
Well, thank you very much. And if you missed any part of this, we're going to have the whole chat will be archived. There'll be video that you can go back and see the doctor's answers to all the questions we got. Thank you so much to everybody. As we wind down, you may see us chatting a little bit as we go away from our chat, but we really appreciate you. Again, I'm Holly Edgell here at WCPO. Dr. Daniel Beierbach of the Christ Hospital, thank you so much. We have some people behind the scenes who've been helping us a lot. Caitlin has been typing in answers. We have Judy here. We have Nikki here for moral support. So thank you again for joining us. Thanks, Doctor.
Thank you very much for having me.
It's
Holly.
great. He's a really nice guy.